This conference will now be recorded.
Thank you for everybody for joining us tonight. I want to thank Dr. Reed for taking the time out tonight to give us a presentation. Just as a reminder, if you can please mute your microphones and disable your webcams. At this point, I'll let Dr. Reed take it away.
Well, good evening. This is Dr. Reed from Reconstructive Orthopedics, and I'm happy to speak with you this evening. I have to admit that when I first chose the date for this, it was probably 5 or 6 weeks ago, and I think this question was probably more poorly answered at that point than it is now, as the public has gotten a lot more information and has been able to make much more sense of what's going on. Even if we don't have many of the answers still, we have a better context. But I seek to try and solidify that with the facts that we know and the story that we have so far about how it came to interrupt our lives so suddenly, and how it's markedly different than anything we've seen in our lifetime. So, as a way of personal disclosure, I'm going to say to you right off the bat that I am not a virologist. I am not an epidemiologist. And I'm not even your primary care doctor. I'm a fellowship-trained, board-certified orthopedic surgeon who does robotic-assisted hip and knee replacement. So, if there are questions that I, cannot really answer appropriately, I'm going to defer to my colleagues who have, superior expertise in certain areas to give you direction if there are any specific questions about your overall health. But that said, I do have some experience in virology. I studied variola virus immune modulatory proteins when I was fulfilling pre-medical requirements, and have been a part of several manuscripts and a lot of the techniques that are being discussed in the lay press, like PCR reactions that are used to test the presence of the coronavirus. Also, I spent some time doing research in my postgraduate studies in orthopedics, studying fracture healing proteins and doing a lot of immunoassays, which is another technique that was or has been discussed pretty consistently in the news for detecting antibodies to coronavirus. So, to begin, why do we need to answer this question? Why do we need to know the difference between coronavirus and the flu? And specifically, it's because all of our lives have been dramatically disrupted, from our daily routines to those that happen on a more protracted basis over weeks to months, planning for vacation, travel, spending time with family, professional development, and overall healthcare. All of these things have been disrupted in different ways and very uniquely for everyone in our community, in our state, in our nation, and worldwide. Non-essential business is essentially severely limited still, although reopening is starting now, and 6 weeks ago that was not even considered likely in the near future. Healthcare access has been restricted over the last couple of months, in part to protect the population, but mostly to preserve healthcare resources, and that has been or had a tremendous impact on access to care and on patients' overall health. Elective surgery has been specifically prohibited, and so our practice at Reconstructive Orthopedics has been impacted dramatically. More than half of our work week has been devoted to operative care traditionally, and at this point we are continuing to do urgent cases only. The good news on this horizon is that we're open to elective surgery beginning Tuesday of next week. So once again, a lot of time has passed as this virus has gotten under more control in our state and community. But physical distancing has proven itself to be a hazard of its own. It affects our overall mental health. It's allowing our traditional sense of community to break down somewhat. There's potential for more and more behavioral illness as a result of disconnection between certain familial and bonds of friendship. And access to services, not just goods and products and life-sustaining things, but access to general services in the home and outside of the home have been restricted. So what is the coronavirus in detail? Well, it began as clusters of atypical pneumonia in and around central China at the end of 2019, and that's why the 19 at the end of the disease name comes from, not because it's one of 19 different variations of the virus. First cases were starting to increase in January in China, and the U.S. reported its first case on January 20th, though that has perhaps been revised by later cases, suspecting that there was earlier transmission. In February, at the end of February, the U.S. reported its first death, and prior to that, the WHO had declared a global health emergency, named the disease COVID-19, and ultimately, several days later, after the first U.S. death, the WHO declared a worldwide pandemic. And as of April 1, there were 1 million cases worldwide. I just checked the most recent numbers, and it seems that there are nearly 5 million cases worldwide as of today, May 19th. So this is in detail what the timeline looked like in terms of case numbers and individual events. You can see that all of the descriptive studies for the condition were during the month of January, before tremendous growth in numbers had occurred. And thereafter into February and March, the thousands of cases were growing, and spread outside of China was demonstrated clearly. There was specific links made between travel to and from China and individual cases in this country. So how does this compare to the flu, right? So the flu is a seasonal condition, and it has an annual incidence that is based on strains that are prevalent in different populations around the world. Due to our global travel, these strains move and mutate and change, and the flu incidence, or the number of people and when and how they get it, are influenced by that travel throughout the world. The natural reservoir for this virus is in humans and aquatic birds, and intermediate hosts have been postulated to be swine, and you may have heard about the swine flu probably about 10 years ago now, and at that point that original strain was transmitted from a pig to a human initially, before there was human to human transmission. However, these viruses are very common in many other mammals, and have been found there, though the ones that are most significant to humans are the ones that reside in human populations and also in aquatic birds. The problem with flu viruses is that they have segmental genomes. That is, their DNA, the instructions for how they are formed, are divided into segments, and those segments can shift around in order in an ongoing fashion. So as they do that, the proteins that those genes encode are changed, just as predictably. And that means that a vaccine is only going to last as long as that particular strain persists. Once there's another shift, the vaccine is no longer going to be as effective, or perhaps could be not effective at all. And so that's why we have a seasonal vaccine that's based on the most prevalent strains that were seen in the Southern Hemisphere immediately prior to our own season. That helps us to be as protected as possible. The annual burden of disease tends to be widely distributed over time. So it begins sometime in late August, early September, and proceeds all the way through April and May of the next year. So even though there are significant deaths from seasonal flu, they happen slowly over time at a very low burden on the healthcare system. This was not the case with the Spanish flu, which was particularly virulent, very contagious, and very deadly. And we didn't understand the epidemiology of it very well at the time, which is why it became so deadly at about the time of the end of the World War I, when there were lots of transport of military personnel and those who were supporting the military, and they were all vectors for the disease. You can see actually on the graphic here to the left the actual spike in death from all causes during the influenza pandemic and when it was at its peak in October and November of 1918. We mentioned the H1N1 and swine flu that occurred earlier in the 21st century, but their overall incidence of disease was in the thousands in this country, not even in the tens of thousands. So it was not nearly as clinically significant as this pandemic. So the name of the virus is not COVID-19. The name of the virus is SARS-CoV-2, but the disease that it causes is called COVID-19. It's part of a group of coronaviruses that are essentially 96% identical to each other, and they live in bats. The bats are not sick with the virus, they are reservoirs of it. So it lives and is in a steady state with the immune system of the bat so that it does not cause disease, but it can transition through a intermediate host. It has a large genome, so it's a set of instructions to create a virus that is larger than the average for viruses, and that allows it to remain relatively stable over time, and that's in contrast to the influenza. There are many transcribed proteins, that is the RNA gives instructions for creating these proteins, and mutations can arrive very quickly and create novel viruses. And in this case, it's thought that the SARS-CoV-2 virus had a spontaneous mutation that allowed it to transition from an intermediate host to a human. Like the original SARS virus in 2003, it also binds the same receptor, and a receptor is a structural protein that's present on the outside of cells in all of the tissues in your body. This particular receptor is involved in some antihypertensive medications, and it's present in lungs and in heart muscle and in kidneys. And these are three of the organs that are most conspicuously affected by severe COVID-19 disease. Transmission of the disease, as I said, is coming out of bats, specifically possibly the horseshoe bat. And there's been a suggested intermediate host of the pangolin, which is an endangered species in Asia, and also considered a delicacy by some of the elite Chinese society. And so it's possible that through one of these animal markets, that there was close contact between pangolin and human, although that has not been clearly proven yet. The virus itself can be transmitted through respiratory droplets in close contact. It is conclusively found on surfaces, though its ability to infect from different surfaces has not been determined. So we don't know the significance of how much virus we find on these surfaces. We do know that it is persisting for longest on plastic, and for maybe slightly less on cardboard, least on metal. And it's extremely sensitive to temperature and humidity. So the higher the temperature and the lower the humidity, the shorter time that the virus can actually survive outside of an animal host. There are viral particles that have been found in aerosols and in feces, although it's very rarely found in the bloodstream. And so these other methods of transmission are theoretical at this point and have not been proven. It's less likely that they will be significant. So comparing the SARS and MERS, which was a Middle Eastern respiratory syndrome that occurred around 2012, and the new SARS coenzyme, or excuse me, coronavirus 2, you can see the different intermediate hosts here. The civet cat was the intermediate host from the bat for the original SARS. The dromedary camel was the intermediate host for MERS, and it's thought that the pangolin may be the intermediate host, as we mentioned. But now, with sustained human-to-human transmission, as you can see at the bottom, no further hosts are necessary for this to remain endemic in human populations. This is an artist's rendering of the structure of the coronavirus, and you can see that it has these pink spike proteins, which are essentially the key it uses to unlock our cells and to enter them. There are several other structural proteins like the membrane protein and envelope protein that give some more support and rigidity to the lipid membrane that basically is the surrounding layer around the genetic material, and that is the RNA, the single strand RNA, which is on the inside. So the basic route of the virus is this. In this schematic, you can see that the spike protein is purple rather than pink, and the blue down here at the bottom is a type 2 lung cell, and this lung cell creates surfactants, which we'll talk about in a moment. But the purple spike protein engages the ACE2 receptor, which we mentioned before, and that's represented by this Y-shaped darker purple structure that's in the membrane. That allows the virus to start to merge with the outer membrane of the cell and ultimately gain entry. Once it does, its own lipid membrane dissolves and its RNA is released into the cell, and it takes over the cell's machinery to reproduce itself by the thousands. Over here on the right, you can see that there's a more detailed look at the angiotensin II type 1 receptor and how antihypertensive medications can limit the amount of signaling that creates adverse reactions in the immune system. And so, although there was some talk early on about whether ACE inhibitors, that is antihypertensives, would make patients more prone to infection, that has not been borne out. It seems that the fact that hypertension exists in the first place is a preconceived or is a risk factor in and of itself, not that a certain medication is used. So it turns out that patients with hypertension or with diabetes are more prone to developing COVID-19. So the symptoms are very similar to the flu, but there's differences in the details. So 1 to 4 days after exposure, you can expect flu, but COVID-19 sometimes can remain dormant or incubating for 14 days. And that range has been sustained by multiple studies over and over, even past the first few months of knowledge of this virus. In the flu, there are many different viruses, and in COVID-19, there is a single virus. There's been very little variation in the genome of the cultured viruses as they've been studied by virologists. So it is a much more stable and singular cause. Both diseases are transmitted by respiratory droplets. Both can cause fever and dyspnea or painful cough and fatigue. However, the flu is much less likely to develop complications like acute respiratory distress syndrome or kidney failure or blood clots. And all of these things have been seen in COVID-19. Another thing that's been seen are cardiac manifestations like things that look like heart attacks, and also cognitive symptoms and loss of smell and of taste. Flu can, in many cases, be prevented with a flu shot, and your overall exposure to flu is prevented by others having flu shots. In COVID-19, there is no such prevention other than quarantining, self-isolation, which is what we've all been dealing with over the last several months. So here's an in-depth look at one of the air sacs in your lungs. It's called an alveolus, and it shows with a lot of detail a lot of different cell types and what they are doing in this lung cell prior to and during an acute respiratory distress syndrome. But backing up and just looking at this air sac, you can see there are millions of these in your lungs that create air exchange, gas exchange. You're able to expel carbon dioxide, you're able to absorb oxygen into your blood vessel. These air sacs have fluid on the inside of them, and the fluid is largely made up of water. Now, water has something called surface tension, and if you've ever seen the top of a glass that is filled past the rim, you can see that the water up to a certain point will not overflow and not spill because it's bound to itself. It's one of the properties of water. It binds to itself to a certain amount until other forces overwhelm it. That's considered surface tension by most people outside of the physical sciences community, and the way to prevent surface tension from collapsing this air sac is for the body to create a special chemical that prevents that from happening. It's called surfactant, and it's like a soap. So at low concentrations, it's not toxic to the body, but it takes away the capability of the water from collapsing that air sac and allows gas exchange to continue to happen. The coronavirus virus, the SARS-CoV-2, attacks the cells that create that surfactant. And so the surfactant is not made, the surface tension goes up, and all of these air sacs start to collapse. It doesn't happen all at once, and they start happening slowly over time. That gives the patients fewer places to have gas exchange, but the lungs are still elastic. They can still move. They're not filled with fluid. They just don't have as much space for the air. And so what doctors have been finding in emergency rooms is that having so many of these cell or alveolus collapsing has allowed them to have significantly less oxygen in their bloodstream, but they're still able to expel the carbon dioxide. It's carbon dioxide which makes you feel short of breath. So there are many patients who don't feel short of breath yet, and still they're having really low oxygen in their bloodstream, which allows them to get sick quickly at the last moment without knowing that they're getting sick prior to it. That's one of the unique things about COVID compared to influenza or any other traditional pneumonia, where the lungs start to fill with fluid first, rather than having these alveoli collapse. This is something that is really useful for hypochondriacs like all of us who are worried that suddenly they have the coronavirus, and yet it's spring, so everyone is having some exposure to tree pollen, and people may be having seasonal allergies. The flu is still present in the community, and common colds are still being passed around. And all of these things can give you upper respiratory symptoms. The thing that differentiates the flu and coronavirus would be fever, right? So if you're having upper respiratory symptoms but without fever, it's more likely to be cold or seasonal allergies. Likewise, if you're having sneezing, that's more common in the cold and seasonal allergies than it is in the coronavirus or flu. And so that's a very good differentiating symptom. But what you can see from these charts is that there is overlap, because there are sometimes aches and pains with coronavirus. There is sometimes a runny nose with coronavirus, although it's not common. There is sometimes diarrhea, sometimes headache. So the most important thing is to be in touch with your primary care provider if you're having symptoms and you can't explain it, or have any anxiety about these symptoms. I can tell you myself, I've been suffering from seasonal allergies, and this has been helpful to reassure me that I have not contracted a infectious disease. So the vast majority of COVID-19 patients end up with mild to moderate disease and do not require significant medical care. This is the estimate as of the end of February, and these numbers likely will shift with time, but it still is consistent with the numbers as we've been seeing from national and statewide data. So here's another a chart that delineates specific differences in the epidemiology of these two things. And epidemiology is the distribution of disease in populations and how it affects them. So again, the incubation period is reviewed. The number of people you're likely to infect, that's called the reproduction number, or R0. And in influenza, you can see that if you have it, you're likely to infect 1 or up to 1.3 people. COVID-19, you're likely to infect at least 2 to 2.5 people. So that means it's more contagious. You have a greater ability to spread COVID-19 if you're carrying it than you do if you have influenza. And the other nefarious thing about COVID-19 is that it is being shed as you're asymptomatic, which is less common in influenza. The onset is slower, and so it's harder to know if you are truly sick, and you are probably doubting that your symptoms are going to progress for several days until you might be suspected of having it from your primary care doctor. Influenza tends to have a very abrupt onset. And we just reviewed the symptoms, so I don't think we have to review them here. There is overlap between the two. Hospitalization rate is markedly different, 10 times higher in COVID-19. It tends to be a more severe disease course. Mortality rate is also 10 times higher, at least. Globally, it seems to be higher than that, but it's likely that we're underestimating the number of infected people just because of limitations in testing, as I'm sure you're all aware of. It tends to affect older adults with chronic conditions, just like influenza. There are some subtleties, and children are less prone to developing COVID-19 and severe disease, although there have been reports of the post-viral syndromes in both cases. Influenza also has some pretty significant post-viral conditions that are generated by it. So I don't know if there's anything very specifically different about this in children and between the two illnesses, other than influenza tends to infect more children. And there is treatment for influenza. COVID-19, we are still struggling to figure what an appropriate or an effective antiviral is for all patients. There have been certain studies that have shown some benefit in a certain subset of patients, and they've been poorly controlled. And the data, unfortunately, is not clear enough yet to guide all treatment going forward. It's all considered continuing experimental treatment. So to give you another idea of how different this is from the original SARS pandemic, on the day that the WHO issued the alert of SARS, you can see the graph moving to the right and how many cases were being added on a daily basis. And the peak ended up being about 4 months later, after plateauing between 2 and 3 months. And after the last case in July of 2004, I believe, there weren't any other cases reported up until the present date. In this case, with the novel coronavirus, the day after the WHO issued their global alert, exponential growth continued for months afterwards. You can see that the growth of the SARS virus was linear. That is, it was going up at a constant rate, and the coronavirus was going up at an accelerating rate. So here's a look in detail about how mortality is determined by the flu and COVID. You can see the same relationship between age groups and the death rate exists, but it's the magnitude of those death rates that is markedly different. And it's, again, at least 10 times more lethal in every age group. Even though younger age groups are more protected, it's still 10 times more deadly for them than it is, or than the flu. And that's one of the things that's most striking and poorly understood. Here's another comparison. If you look at the previous flu epidemic, the H1N1 in 2009, this again is looking at the WHO's announcement. You can see that after the 60th case, coronavirus and H1N1 cases were continuing to go up by the thousands. However, confirmed deaths of coronavirus were going up far more quickly and consistently, whereas H1N1 was not a lethal disease, comparatively speaking. And so the numbers are just completely different in how much they affected the healthcare system in that setting. So how big is this going to end up being? Right now in the United States, the projections are anywhere from topping out at 100,000 to close to 300,000 deaths. And it is unclear if these numbers are going to remain consistent, because all of our social distancing and the way our society has changed to try to flatten the curve, all of those things are in flux, and presently we're reopening a lot of society. So these numbers and projections may continue to shift with time. However, if you get an overall sense, you can see that the swine flu in 2009, H1N1, had the smallest effect. The seasonal flu from last year was 34,000, and the year before was nearly twice that. However, those deaths were sustained over more than 8 months. At this point, we've sustained, well, let me see. I'm going to look directly at the most up-to-date data. almost 92,000 deaths as of this date from our first death, which was a little more than 3 months ago. So the magnitude of the problem is severe, and we are not finished. The pandemic goes on, and the number of deaths until we reach a low plateau, if we are to reach one this year, is not difficult, or is not easy to predict. You can see that the 1918 pandemic was significantly greater during that time. It's a question of whether COVID-19 will have numbers that approach that or not. The optimistic thing, though, is that it is not nearly as lethal as other viruses that we understand fairly well or not as well. You can see that Ebola is incredibly deadly, but there are very few cases of that worldwide. They tend to be very confined to African countries. There's been 1 or 2 reported Ebola cases as of 2014, I believe, and those did not end in death, and there was never any outbreak in this country. The Middle Eastern respiratory syndrome tends to be much more lethal than the SARS or COVID-19 so far. Thankfully, it has had very few cases, though it does continue to pop up from time to time, mostly in the Middle East. Smallpox, which was historically a great scourge in this country, had a 30% mortality rate and has since been eradicated. So it has a much darker history than any of these modern viruses, save MERS and Ebola. So you can see that the original SARS had a nearly 10% mortality rate, but COVID-19 is below that, thankfully. The difference with COVID-19 is that its incidence and the number of cases far exceed SARS, and therefore far exceed the absolute number of deaths compared to SARS. And you can see that measles and seasonal flu have a very minimal effect, or minimal death rate. So if we look at the hospital stay and the burden on hospitals, COVID-19 has about a 12-day average hospital stay compared to 3.6 for the flu. So patients stay longer. Hospitalization rate, patients stay more often, 10 times more often. And we already reviewed differences in fatality rates. But one of the biggest things about the flu is that there is herd immunity. And that is the fact that the people that you come in contact to or come contact with throughout your life are unlikely to carry influenza and therefore give it to you. It's not because you have built up immunity to all of these viruses, it's that everybody else has, so that they don't contract it in the first place and they don't bring it to you. That way, it's really only about 8% of the US population that remains vulnerable to influenza A and B strains. However, COVID-19 is or has the potential to infect 50 to 80% of the population in this country based on epidemiologic models, because there isn't any herd immunity against it. Despite being infected with coronaviruses for the common cold, it affords us no lasting immunity and no specific immunity for this particular virus. You can see that the hospitalization rate tends to be about 50 to 100,000 persons overall, but in older patients, it's much higher, and once again just underlines how important it is to protect the older populations. You can see the reproduction rate of flu is 1.3, and again, reproduction rate of COVID 2 to 3, which we saw in one of the graphs earlier. And regarding how COVID patients are contagious. You can see that they're shedding prior to symptoms, and this has been demonstrated 48 to 72 hours prior to the beginning of sickness. Studies done at the University of California at San Francisco has shown that the virus can be measurable for 12 to 20 days during the course of disease, which is a very extended period of time for potential transmission, and one of the factors that probably contributes to the reproduction rate. And another small but significant observation by the doctors on the front line has been that COVID dyspnea, or shortness of breath, tends to interfere with activities of daily living, whereas shortness of breath in other pneumonias or in influenza pneumonia may or may not be as difficult to manage. So, in summary, there's no herd immunity to COVID-19. It has a longer incubation period. It's more contagious. COVID lasts longer. It has a higher hospitalization rate, longer average hospital stay. It's more deadly. And so, therefore, physical distancing protects others from COVID-19. It may not protect you, but it's protecting others if you are carrying it. And wearing a mask protects others from COVID-19, even if it doesn't protect you. And that is one of the more difficult things about all of the measures that have been implemented at the state level and by your healthcare community to control these, the transmission, because the idea is that you are giving to others by doing these or taking these precautions rather than protecting yourself. That said, we are using all of these precautions ourselves in our orthopedic practice. We have limited the patient numbers and guests to ensure distancing at all times. We've been screening all of our patients prior to visits, screening all of our providers and staff, and using virtual waiting rooms. We have PPE for all staff at all times during the clinical space or within the clinical space, and we are using rigorous disinfection of every room after every patient visit. Most of our providers are using telemedicine, and it's widely available for all who are interested. We can do everything save X-ray, and it's been really satisfactory from our point of view, and I think the patients have really enjoyed it. Our Ortho Express urgent care remains open, and we want to remind you that we are part of your community, and we look to continue serving you in as safe a manner as possible. And we look forward to seeing you. So thanks very much for your attention. This is not the typical orthopedic talk, and so I apologize for bumbling at times, but this has been a very overwhelming topic for everyone, and I hope that I was able to at least add something to your understanding and to make us all feel a little more collected in our task to minimize its impact on our lives and to keep us all safe and healthy. Thanks, David.
Thank you so much, Dr. Reed. This was great information for us. I'd like to open it up for questions right now. If anybody has any questions, you can feel free to use the chat box or go ahead and unmute yourself and go ahead and ask your question. All right, well, it doesn't look like there's any questions. I think you answered everybody's questions. So again, I want to thank you for your time and thank you for everybody's time for joining us tonight. This talk will be on our website by the end of the week, so you can always reference it again.
Thank you all.
Thank you.